Thank you for the introduction, and thank you very much for inviting me to speak today. And many congratulations to SJK for mounting this in very difficult circumstances. A great achievement, thank you. I'm talking briefly about what I call the 3 ages of CUP. Because really, unless we look at where we've come from and look at where we are, it's difficult to focus on what is next. So we pass over the Stone Age into where we are now, the scientific age. And the important point that I would get you to recognize on this slide is the anatomical focus of treating CUP, sometimes referred to as chasing the primary. And we're moving into a new age of CUP, a very exciting new age, where the anatomy is of less important, and there's a recognition that cancer in general is a disease of the genome. And I'll come back to that and expand it in more detail. I'm covering fairly briefly and fairly quickly the 3 things: where we've been, where we are now, and where we might be going next. But I realize that others much more qualified than me will be picking up on where we are going next. Just to get us into the same ballpark, we're talking about cancer of unknown primary, no anatomical primary identified after initial clinical evaluation. Note the heterogeneity of CUP, which you'll probably all be fully aware of, and that we're talking about carcinoma of unknown primary. There are a number of hypotheses as to why the primary is and remains occult, very small. All we really know is that metastasis happens very early when the tumor is very small. And it becomes something of a moving target as it spreads around the body and finds sanctuary sites to hide, sheds cells, and alternatively, possibly even regresses. This is possibly a point as much for discussion as anything else, if anybody wants to discuss it. When I first started looking at the literature on CUP 15 years ago, there were essentially, it could be boiled down to 2 hypotheses. That CUP is a clinical presentation of METs in patients where the primary tumor cannot be detected, and that has been the most popular understanding and designation of CUP probably over the last 15 years. But another hypothesis, which is yet to be proved or disproved as far as I know, is that CUP forms a distinct biological entity. As I say, I'm not qualified to really comment on those hypotheses, but it might be for the experts in the audience to pick up and discuss where we are now. Essentially, from my understanding, we really just don't understand the biology of CUP, and we're some way off from doing that, although some exciting genomic developments may lead towards that understanding. We are clearer about what we are now in the UK constituting as CUP, and it's ICD-10 codes C77 to 80. And since 2010, that is how we have been classifying CUP. Other countries do it differently, and I've put at the bottom of this slide some of the other codes that other countries cover embrace as part of carcinoma of unknown primary. And I have to say, I often wonder why C76 is not included, but there was, in fact, the numbers are very insignificant were you to include C76 in our epidemiological data. This is a good news slide. CUP incidence and mortality in the UK has been falling fast, and using the designation of ICD-10 C77 to 80, we can actually show that diagrammatically. I would point particularly to the box in the middle of this slide, where the latest data that is available, which is for 2017, CUP is showing as the 15th commonest cancer in the UK, whereas 10 years ago it was the 7th. The ratio of one male to 1.2 females has always intrigued me, and it's been fairly consistent in the 15 years that I've been looking at CUP. As a social scientist, I'm always interested in outliers, and I have no idea why that is the case, but it's intrigued me that it always seems to be fairly consistent, albeit not terribly significant in the difference between the two. Now the 6th highest cause of cancer death in the UK, but for many years until 2017, it's been the 5th highest cause. So that's, again, is good news. Less good news is that it remains a major burden for the health service, particularly with a very significant number of patients presenting as an emergency. That figure is from a fairly old study, but I'd be surprised if it's much different today. This is just reinforcing the significant drop in incidence and mortality, which has been moving at a faster rate, indeed, than other cancers. Let me just put this in an overall focus. Take a look at the timeline. The first mention that we can identify that might be attributable to CUP goes back to Annals of Surgery in 1907, an American author on non-demonstrable cancer. If we go beneath the dotted line, the years where I have been interested in, or more interested in CUP, we've seen that period before the important date of 2010, which was the introduction of the NICE guideline for CUP. Before that, very much treated as an orphan disease, a very nihilistic approach by the medical profession with, I think, agreed suboptimal treatment. If one was to ask people who were practicing in those days, there were no definitions. Well, there were a lot of definitions, but no consistent definition. Treatment was ad hoc, and there was very, very little research. There was about 1 or 2 papers when I started looking at this 15 years ago that had a UK author, and the majority that did exist were from America. 2010 to 2021, we are in a new ball game with new opportunities, with a managed pathway and a well-recognized disease. If I look at this in a slightly more detail in a phased way, people in that first phase were bouncing around MDTs like tennis balls with no one taking ownership. It was something of an inconvenient truth. And then after the NICE guideline, CUP became a diagnosis in its own right, rather than a failure of diagnosis. And since then, the patient pathway, with a clear patient pathway, patients have benefited enormously. Also, the oncology world has found that CUP is interesting, intriguing, and is not a career death knell that it was in the past. We're moving into the new age and heading towards the end of CUP, I think, as a designation, but it's really only affecting people who are on trials at the moment, who are benefiting from the molecular revolution. Let me talk for a moment from the patient perspective, which is really the only one I'm qualified to talk about, and remind ourselves that the patient is what it's all about. And I think from the patient perspective, CUP is what I call a double agony. You're told you have cancer, and you are told that nobody knows whereabouts in your body it has come from. And there is still obviously the recognition that cancer treatment is predicated on identifying the primary anatomical site. So I think the patient is saying why, in this very scientific age that we live in. It might throw unfairly some doubt on the capability of the medical profession. And obviously patients want to know how long they're going to live, when they'll get treatment. And a question that comes up a lot, I find, is a question of whether CUP is hereditary, because people are obviously frightened in terms of their children and their other relations. The CUP patient needs rapid referral on presentation, and we have in the UK MUO teams, metastatic malignancy of unknown primary origin teams, as part of the CUP team, who have become very expert in identifying whether it is indeed cancer, and if it is, whether the patient can be diverted to an anatomical primary site for directed treatment, or whether it really is a true CUP, in which case there is the pathway that they then fall into and are managed along a very clear algorithm. So the rapid expert-led assessment is important, as is appropriate investigation. And I do emphasize the appropriate, as there is a tendency sometimes to face patients who are in a very poor state with inappropriate investigations. And I would always urge that palliative care is seen as coming in early in the pathway and not as a last resort. Research we've done and others have done show empirical evidence as to what the patients are experiencing: anxiety, uncertainty, amplification of pathway management problems. And if you compare this with patients with other metastatic cancers, it is genuinely seen as a bigger problem, with higher rates of depression, higher anxiety, and worse emotional and cognitive functioning. Recognizing this, we have developed in recent years a series of decision aids, which are available on our website, to try and help patients and their carers to identify their way through some of this nightmare of what they should do and what's going to happen to them. Heading towards a conclusion, CUP, I would say, is on the cusp between the old and the new, the traditional route and the new exciting genomic dawn. But it'll be some time before the patients start to, or the majority of patients start to benefit from this new genomic dawn. I asked Tony Greco, who with John Hainsworth, they have been the leaders in CUP research over the last 15 years in America. I asked Tony for his view on research themes in 2018, and that captures his view of the three main research themes which are around the world, going around the world at the moment. And I'm pleased to say there is a lot of research, and Capisco, which I know you've signed up for and is taking place in Ireland, is one of the exciting pieces of research. I think with research I would suggest some interesting dilemmas. We've seen a lot of suggestion that of changes in treatment, but not all those changes have led to, or a few of them actually, have led to a change in patient outcomes. And that's really where we need to be heading, is to change patient outcomes significantly. We don't yet know about immunotherapy treatment, whether this is going to have a significant impact or not. And there are a couple of trials now, including Capisco, which will help give some sort of answers towards that. I've mentioned CUP biology before and our failure to know much about it. And again, we might be heading towards a few answers with that. So what needs to be done? I put this slide up for a conference some years ago, because I think it's important that we don't just focus, those of us who are interested in CUP, on clinical therapies, but also issues around service management and palliative care. Diagnosis is obviously key, because improved diagnosis will, again, speed that moment when CUP comes to an end as a classification. That pretty much concludes my presentation. I would urge you, if you are interested, to look at our website, either for the patient decision aids, but also we have a wealth of information in the research section of our website. Information about previous conferences which we have held, the various treatment guidelines from around the world which are of interest to clinicians, and the literature that we have gathered on CUP from different sources, which provide hopefully interesting and valuable reading for researchers. Thank you. That concludes my presentation.